for tonight's presentation. We're going to do a brief, I'm going to attempt to do some brief introductions just because this is a broad group of industry participants from all different places. So we will spend a couple of minutes doing some introductions, and then I'll give a brief project overview. We'll reach the bottom of the hour discussing some things called use cases, what use cases are and what use cases apply to this project. And then we'll spend the majority of the second half talking about functional requirements that we're looking at, what that means to the content that needs to be exchanged in these personal advanced care plan documents, and what our strategy is going to be for representing that information in a vocabulary, a standard way. And if we do a good job of getting through all of that, there will be a few minutes at the end where I can talk about what it looks like going forward, ways to participate, perhaps if you are not an HL7 member and you have interest, or you guys can just give me some other guiding feedback at the end. So I'm going to watch the clock pretty closely to try and guide us through all of that content. My down arrows are not working, but next works. Okay. So as I said in the little reminder last night, this meeting is to discuss sort of what I'm calling non-technical issues. We've really gathered this group of industry experts to help us focus on things that sometimes the HL7 standards gurus maybe don't focus on. So this is a higher level, lift up our heads and look out into the care challenges that we face, and focus not directly on making CDA templates or specifying an implementation guide, because I'm really working through those issues by translating the information that you guys share here and working with the technical team to do those things. What we'll be focusing on as a team here is making sure that this project is looking at the right set of guiding documents to inform what it is that we're trying to do, to make sure that our use cases are really covering the right set of scenarios that are needed so that what we build this round will have valuable benefits for the stakeholders that are involved. And then to make sure that the functional requirements that we're aiming to address right now are full enough to get us started and to sort of suggest what content needs to be shared in order to make that kind of functionality possible. So those three things are the things that we'll be looking at tonight. And over the course of this project, this group will really be a place where we can make sure that that everything that we're doing at the technical level really remains relevant and valuable. So I thought, because all of you don't know each other yet, we could take a couple minutes. I think if you look at the participant list in the WebEx, you can see your order. I think it's probably sorted on first name alphabetically, and maybe if you can get to your mute button, and we'll go through that way. Share your name and your organization, and then your interest in seeing advanced directives, or what I've been calling in the time of care planning and focusing on care plans. We really are looking at these advanced directives as advanced care plan information. So what your interest is seeing that kind of information shared in a standard digital format so that clinicians can have the information that they need to take care of people, and people can feel confident that their goals and preferences and priorities will be heard. Just interested a little bit in your level of interest and what brings you to the project. And then if you have any experience, past experience, working on HL7 ballots, that would just be a nice to know. So let's just go around the room here in a virtual way. If Bob, if you're able to unmute and just give us a couple brief words.
So Lisa, can you hear me?
I can, yes.
Okay, perfect. Hi. Okay. So Bob Fine. I'm Director of Palliative Care and Clinical Ethics for Baylor Scott and White Health, and I think our interest in this is, our healthcare system extends over half the state of Texas or more, and we've been interested in digital advanced care planning for a long time. We have patients that come in and out of our healthcare system from other systems, so anything that enhances that communication about advanced care plans and advanced directives to us is just a big plus.
Awesome, thank you. And how about balloting? Have you
No.
joined or? Okay, super. Mr. Scheller, Brian.
Hello, my name is Brian Scheller. Work for Helpline. We have initiatives both around advanced directives and care plans, and I've been working with HL7 for about the last 3 years.
Thanks, Brian. David?
Hi, I'm David Tao. I work for ICSA Labs. I have been involved with HL7 quite a bit for many years, including structured documents. I have a personal interest as a consumer in this, and also a trustee for my parents who are aging, and also my future children and grandchildren. But I'm particularly interested in liquidity of advanced directive or advanced care plans, because I think the current form, most of them being on paper, whether they're in a standard format or not, they probably aren't even going to get to the right people when needed. So I think first, being electronic, they can be liquid. Secondly, if they can be more standardly structured so that there could be more decision support based on that for the future, that would be a nice thing too. Thanks.
Terrific. Jeff, I see you. Oh, I'm sorry, David. After David comes Douglas.
Yeah, it's Doug Renfield Miller. I am an advanced leadership fellow at Harvard, and here I am working on a project where I formed a nonprofit called Good Ending, which is trying to improve end-of-life outcomes for individuals. So my focus is on the individual, and I was brought into this by Jeff Zucker at My Directives, because My Directives created the app which I was trying to create, going to the idea of liquidity, about having something that's easily accessible at the individual level. So my focus is more on the individual level, but I'm here as a very interested listener.
Great, great. How about balloting? Will the balloting process be new for you?
Yes, and I have to look up HL7 now too.
Okay, I'll send you some tips at the end here. Judy.
Hi, I'm Judy Paris. I'm a clinical social worker, also joining you all via Jeff Zucker, and thanks to him for that. I was in the Assistant Secretary's office and helped work on the Advanced Care Planning report. And those of you who may be familiar with Jenny Harvell, I did have, unfortunately, the experience of trying to do an HL7 ballot to get the advanced directive in the electronic health record. I also just, fortunately, had recently been on the IOM committee that issued the report Dying in America.
Awesome, awesome. Well, I hope that we'll be able to improve your experience with HL7 balloting, so you'll have a much more positive feeling about it at the end of this project. Jeff, sorry, I didn't mean to jump over you. Let me come back to my J's here.
No, that's quite all right. It's Jeff Zucker. Scott Brown and I are the co-founders of AD-Vault My Directives, and we're based in Dallas. Some of the folks on the call were invited by us, given our work in this space now for over 8.5 years. We got into this space similar to, I think, David's mentioned earlier, and Brian's. We're interested because of personal issues with our own families, but we saw a massive opportunity and a big challenge in healthcare. So we don't see it as a problem, we see it as an opportunity. And we're learning a lot about the HL7 process as we go through this, so I appreciate the chance to participate in this call, and thank anyone that we've invited that's been able to join in and offer their expertise as well.
Thanks. Yeah, thanks, Jeff, for helping to shake out such a great group. Melinda Owens.
Hi. I'm also in Texas. I'm an informatics nurse. I am in this group because I am passionate about consumer engagement and empowerment and the duty of clinicians and healthcare IT people, personnel to support that engagement and empowerment. And I think that at the time when this sort of document is needed is the time of greatest chaos in anyone's life, and the family is completely dysfunctional at that time. And so I think that being able to get this sort of directive into a portable document is the best solution. And I've not done balloting before.
Awesome, but Melinda's going to be an HL7 expert by the time she gets done with this, so it's going to be all right. Remington, welcome.
Yeah, so my name is Remington Johnson. I'm with St. David's Healthcare and HCA down here in Austin, Texas. I chair our ethics committee, and I'm a hospital chaplain. So the chaos that Melinda talked about, that's where we get to sit in our ICUs as we try to make hard decisions. So these advanced directives, I think, are just, it's a really super important way to do this, and the easier we can exchange them from hospital system to hospital system. Like here in Austin, it's almost a 50-50 split between the two hospital systems, so there's a good chance that if I didn't do an advanced directive with a family, that my peers across the street did. But there's an even rarer chance that we have the ability to share those copies kind of, I think someone said liquidly. And I've got no prior HCA HL7 balloting experience.
Awesome, thank you. Scott Brown. Scott, are you have voice? Yep.
There I am. Okay. I was muted. Sorry. So Scott Brown, as Jeff said, he and I are the co-founders of MyDirectives.com. We've been working in this area for almost 9 years now, and with users all across the 50 United States and in more than 20 to 30 foreign jurisdictions, we've seen firsthand what Judy Perez saw way back in 2008, and what Bob Vine has been seeing for years, and what everyone else has seen for years, which is there's a discord between vocabularies and structures within advanced directives and advanced care plans that, even when they are existent, make them almost, which give them very little value from a practical standpoint. So it has been our mission all along to standardize the structure and the content of those documents so that someone from Rhode Island is speaking and using the same terms as someone from Northern California, and the same person is using that language in the United Kingdom. So that is our business interest in doing this, and obviously, as Jeff said, we have a personal interest in making sure that these are high quality documents, because that's our mission. So I appreciate everybody joining the call as well and joining this group.
Thanks, Scott. Stephen Chu.
Hi, good afternoon. Thank you, Lisa. I'm Stephen Chu. I am one of the co-chairs of patient care. I'm also a nurse and a physician by training, and have been in the past a consumer of the advanced care directive information. I'm interested in this piece of work or project because of my patient care work group background and my clinician background, and also I have experience working in Australia, where we produce a national EHR specifications for the production of a number of clinical and also consumer generated document, and advanced directive is one of them.
Awesome.
Thank you.
Awesome. Stephen has lots of
by the way, I
balloting.
do have HL7 balloting experience.
Awesome. And Swapna, I can't tell if you have voice connection. Are you able to introduce yourself?
Yeah, can you hear me?
Yes.
Okay, great. Hi, everyone. My name is Swapna. I am new to the ESAC team. I work under Jamie Parker, and I'm just on this call because I'm interested in learning more about HL7, and like I said, I'm new, so I just want to learn about everything that's going on.
Awesome. Awesome. Somebody with a fresh view, so that's really terrific. Tony.
Yes.
Hi, can you hear me?
Yes.
Okay, my name is Tony Chow. I am brought to this meeting by Jeff and Scott. I actually reached out to them a while ago as an interested venture capitalist, So as a venture capitalist, I will try my best not to bring the intellectual level of this meeting down too low. But I am also a cardiologist by training and practice in San Francisco at UCSF and the VA, so I bring some of the practical experience. And other than that, I joined the group that barely knows what HL7 is, and I've never done any kind of work with it.
Awesome. Well, welcome. What an amazing group of people. I'm honored to be a part of it. As I told you earlier.
Lisa, this is
oh,
John
did
Durr.
I miss? John,
Yeah, well,
sorry.
I'm not on the GoToMeeting website, so.
Oh, there you go.
And I don't have access. I'm in Texas, but right at this moment, but I don't have access to a computer. And I tried to get it on my iPhone, but it didn't work. So.
Thanks. Yeah, and we have someone in Massachusetts who's driving in their car too. So we have 2 more to do. You go ahead, John.
My name's John Durr, and I was also invited, and thanks Scott Brown for all the work that he does in bringing the advanced directive to people's attention. And I'm on the Federal Advisory Committee for Standards. I've been interested in the advanced directive for many years now. I'm a pharmacist by training, although I've been in industry most of my 50 years of healthcare. I was the Executive Vice President of American Healthcare Association and a CIO of Golden Living, which is a long-term post-acute care company that has over 60,000 people under their care at any one point in time. And I formed the LTPAC HIT Collaborative, of which Jenny Harville is a member of, in 2005, after President Bush's press conference forming the digitization of healthcare. So I've worked in the S&I framework, and in my balloting experience has been with the LCC, and we had balloted and just got approved, but I'm not a member of HL7, but have been aware of everything that you guys have been doing for years and years. My interest is long-term post-acute care and longitudinal care, person-centric electronic longitudinal care, and the advanced directive. One of the things I've been trying for years to get inputted into the directive is not really just care, but quality of life. That a person should have in the directive that this is the quality of life that they want to live. And since I live in the state of Washington and now the state of California as well as Oregon, we can check out with the doctor's permission if our quality of life is what we want it to be. My example of why I got interested in this was one of the calls on the S&I on the Standards Committee. Somebody asked if she's just been admitted to a hospital where her advanced directive was, and if she had one, she said yes. And he said, well, may I have a copy? And she said, it's in my safety deposit box. So that liquidity that somebody else mentioned earlier on is important, but the 2 important reasons why I want to be part of this group is I've also been part of patient engagement workforces and work groups underneath ONC, is really longitudinal and the quality of life.
Good, John, thank you. And I think Terry O'Malley may also be, yep, go ahead, Terry.
Yep, that's great. And it's always my pleasure to follow John Durr. I'll follow him anywhere he goes. It's a great group. So I'm also a long-term post-acute care person. I'm a geriatrician at Partners Healthcare in Boston, a big integrated, allegedly, delivery system, which has a tough time getting advanced directives in the right place. I've also helped lead the transitions of care and the longitudinal coordination of care work groups under ONC, and the latest S&I work on the ELTSS, Electronic Long-Term Services and Supports work group, which is working on the content and specifications for a care plan that can be exchanged among long-term service and support providers. And at the heart of that is really the individual's statement of their priorities, what matters most to them. And I think what this work group is about is really sort of the final piece in getting what the individual values most in the hands of everyone who needs to have that. So it is my pleasure to be part of this. And I have done HL7 ballot work.
Great, great. Well, we're glad to have all of you.
You said one more, I'm sorry.
Oh, okay.
Also not on the computer. My name is Dan Hansling, invited by Jeff. Thanks very much, Jeff. I am a practicing emergency physician. I am the chairman of the Institute of Medicine's Forum on Catastrophic Disaster Preparedness and editor, co-editor of 3 volumes on catastrophic preparedness, specifically around palliative care and managing patients in the scarcity of available resources. So I'm interested in this discussion both from that perspective as well as from my day-to-day practice as an emergency physician. I practice just outside Washington, D.C. And I've not been involved in HLA 7 balloting, but I was involved very extensively in the Assistant Secretary for Preparedness and Response's office effort on coordinating bed reporting across jurisdictions across the United States, something called the HADBED project. Thanks.
Awesome. Welcome, Dan. Thanks for the introduction. So my background that really brought me to this group is that I'm a medical informaticist who's very heavily involved with standards in the HL7 space and in another standards development organization called IHE. Now, when I finished my during my medical informatics program, I realized how important this role of the consumer and how we could really change things by doing that. But I noticed that not much focus in the standards world was on documents that could represent and communicate information from patients, and that people in general didn't know much about personal health records. So I started something called Janie Appleseed, which was my little effort to try and educate people. And then I used my standards work to bring a patient-generated document header template into the development of consolidated CDA to make sure that we got the voice of the consumer really enabled right at the same time. I've been doing quite a lot of work with the care plan document templates in Consolidated CDA Release 2, and I'm also very active in the development of electronic clinical quality measures. So my technical background and standards experience is going to help us harness all of this amazing expertise that we have in this group to make sure that we really bring this project to something awesome. The goal, I do have some background noise. Everyone could maybe just give a double check and make sure you went back on mute after your introduction. The goal here is to create what HL7 calls a draft standard for trial use, DSTU, for a personal advanced care plan document that can be used to get digital information sharing started. I'm not promising that we're going to accomplish everything that everybody has in their minds today about this, but we know that we don't have enough to really get started. And so this attempt is to make sure that we get started at least in the right direction and that we're not doing anything wrong, but that we have the sufficient amount of information to be beneficial and not harmful and really kind of cut us loose on beginning to have a way that patient information can be shared. We're trying to shift the focus into looking at these advanced care plan documents as more of a clinical care planning kind of thing rather than just a legalistic documentation perspective that you see from advanced directives kind of right now. And to make sure that we're clarifying the industry's mind around what the use cases are and the benefit from being able to share information like this. So very narrow purpose. We're really working to just establish this CDA format for being able to exchange interoperable digital information. I heard a couple of people use longitudinal. Nobody used interoperable, but interoperable is really information that is more than just what what you can see, but something that computers can process to be able to do something more with than just make visually accessible. So interoperable digital sharing of a person's advanced care plan information. Why CDA? Right now, CDA is our best bet. Some of you may have heard about an emerging standard called FHIR, and it's something that's out there and that is coming, but it is not my primary focus in terms of enabling the industry right now. And what is being used right now and has large uptake and will be available for years to come, good investment right now is to express this in a CDA kind of way. It stands for Clinical Document Architecture, and it's one of the most prolific standards that's being used right now to exchange this kind of information. This project, because it does enable patients or people to express information in new ways that really have not been there before, if it's anything like what my experience was in developing the patient-generated document header, it's going to be a bit disruptive because it's just new, and we're just going to be braving into some new areas. And so in order to help guide us through that, I am keeping track of what I call guiding principles, and I will just show you briefly for those of you who want to brave your way into looking at information that HL7 records. This wiki, wiki.hl7.org, will be the place where we keep all of the material that accumulates over the course of running this project. And I've documented some guiding principles right here that mostly have to do with what we've discussed so far, the scope of the project, what we're going to do in terms of collecting input from various different places, running it through a structured documents that's a group within HL7 as a governing body, and then making sure that we come out with something that's expressing goals, preferences, and priorities, other types of information that's typically expected or hoped for in advanced directives documents, and then to make sure that all that lines up with the work that's already been done around consolidated CDA and care plan documents in general. So that's what's going to be kind of guiding us through our work. We're on a very, very tight time frame. This will be one of the fastest projects that I've ever run. We have to have our use cases established and everything like that in September, October. I really have to have the main document that will go to ballot ready by the end of November. During December and January, this work will be available for public comment for anybody who is participating as an HL7 member to put in comments against that. And then we work through all the identified issues, consolidate that back into a final document, and publish that as a draft standard for trial implementation by May 2016. So it's very ambitious, but with a group like this, I feel like we could accomplish anything. So use cases, I just wanted to kind of introduce this concept in case you haven't bumped into the term before. I think of it as a kind of a technical term. It does have its roots in how requirements are brought together and documented, but I like to describe it as our set of scoping scenarios. And when you take on solving a particular problem, the scope of what you solve is constrained by how big you think the problem is, or what things are involved in what scenarios are involved in the problem. And so it matters to the design that you eventually come up with as to what stories, what scenarios you consider in or out when you get started. And I like to use the example because I'm besides being one of my things as Janie Appleseed, I'm a big privacy advocate, and I really believe that that privacy and consent is something that people should have control over as their information goes out into the world and begins to be used and shared. And one of the reasons that I point to as to why privacy has been such a left out situation is because in the early design considerations, stories about how we control and consent and keep track of to allow the sharing weren't really in the set of scenarios that were taken on to design some of the early systems. And as a result, the designs that we have are now facing privacy issues as sort of a secondary consideration. But if you start with the right use cases in mind, I think you get a better quality design right from the get-go. So one of the things that we've done in sort of setting up and planning for this project based on prior work is, rather than kind of coming to this group with an empty slate, I have identified 5 use cases so far that I know technical scenarios need to be able to address. I'll explain what they mean. First of all, creating and sharing an advanced care plan is you know, the way that you get started. The reason why I've combined the 2 verbs, create and share, because in this effort, which focuses on what content needs to be shared, creating the directive is more of sort of a precondition, and it sort of is assumed that there is a way to create the directive, because otherwise you don't have anything to share. But the use case in the creating interoperable information is really about how that information can be instantiated in some kind of a format that someone else can consume it. Secondary kind of to that is the notion of updating that plan and then sharing that. And so we know in care planning that this iterative nature of not just creating them, but integrating and updating, and that has to be considered as a use case. Revoking an advanced care plan is something that, through my research, as the paper documents are explained to people, they always include, which I think is good practice. If I'm going to explain how you put something in place, then I should also explain how you shut it down. And so revoking an advanced care plan has sort of 3 specific ways that it can be done: replacing it with a directive with a newer version, establishing an end date when it would expire, or explicitly revoking it. That's what I've discovered as ways to revoke. And then from the other side of the story, this is in the, you know, the first 3 are from the side of sort of the person who's making the directive. From the person who needs the directive, a clinician, an organization who's caring for an individual, these other 2 use cases come up. First of all, to the need to request and access the current version of that advanced care plan in a situation that is emergency or critical. And we know that that is different than situations where that request and access to the current version is more of through the course of regular care, and including in a larger care plan for the individual, et cetera. So I've made this a little bit binary in the way that I've worded it, so that we have use cases both that are in an emergency and critical situation, or use case that is not. I'm going to stop for a second. I know we're going to get tight on time. I still have one more big slide to get through. But does anybody have anything that you really want to inject at this point about use cases that perhaps I have failed to consider?
Lisa, this is Stephen Chu here. A couple of comments. Number one is that I am aware that the Child Health Care Group is working on documentation for children with special health needs. And one of those components involve some form of advanced care directives. So I think it will be useful to touch base with the Child Health Care Group to foster some synergy and or collaborative work to determine where the touch points are, how the information can be cross-fertilized. So I think that's number one.
Thanks.
Number 2, in terms of use cases, we probably need to think about whether or not I will entertain some of the edge cases, and if not, then we probably have to, at the very beginning, declare some of those edge cases out of scope.
Okay. Can you send me a list of what you think edge cases would be?
Okay, I will have do some thinking and then send you some examples.
Okay, thank you. Anybody else on things that, perhaps should be considered in thinking about our use cases? Okay. Oh boy, now I got a whole bunch of. All right, there's the slide I'm looking for. Okay, so I'm a little bit behind on time, but I think we're still going to make it. So the next step, after thinking about those use cases that we want to be able to address, I was thinking about the functional capability that needs to be in place. And these 5 bullets, I'll ask the same question. Are we missing anything from this basic capability? And again, keep in mind, I'm thinking about what is a must-have to get started as opposed to what is the ideal with the scope of everything. So I just want to make sure that I have a sufficient scope for the problem to get us rolling. So number 1, express goals, preferences, and priorities. I gave a couple of examples of what we mean by that because it's kind of a new term. Not new, establishing healthcare agents, communicating living will choices, indicating donor, organ donation or autopsy choices. These are choices that are made upon death. And then identifying with whom an advanced care plan should be shared. So those 5 main capabilities is what I've kind of carved out as what we want to aim for that would be sufficient to get started and sufficiently valuable. Would anybody want to suggest that there's other things that we need to be able to do that aren't in this list so far?
Lisa, this is John Durr. I would assume then that quality of life would be in the goals, in that number 1?
Yes, I'll note that.
Thank you.
Yep. Anybody else have a particular thing they want to add in?
Lisa, Terry O'Malley, and maybe this is a bit out of scope and on the edge, but it has to do with healthcare agents and the whole issue of substituted judgment and whether that's sort of prior to the plan that's going to be exchanged or whether that has to be thought of as an extension. Because a lot of the individuals who need advanced directives are going to get them through substituted judgment.
Okay, I'll email you about that. I love the term. That's a great term. I'd like to. I think I read some questions the other day that I would put in that category, but let's talk about that. Yeah, I think that's important. Also, with like dementia patients and stuff like that too, that'll be important. Yep.
This is Judy. Along those same lines, with regard to the substitute judgment, I guess you would need to be able to capture whether it was going to be an organization that was the person's agent or a guardian or some other more granularity to that.
Okay, got it, yep. Okay. What I'd like to show, so if you think of anything else, if you don't think of it right now, but you think of it later while you're driving home or whatever, my last slide is my email address and my cell phone number. Just call me because this is the perfect time, or email me. This is the perfect time to be fleshing these functional capabilities out a little bit more because it affects what content we need to have the ability to exchange. And I wanted to show you what I have been doing in this space to, let me see what I need to do here, Alt-Tab, I think.
Lisa, this is John Durr.
Yep.
Are you sending us the slides, the PowerPoint?
I will.
Thank you.
As soon as our call is over, I'll send the slides and the link to the recording if all goes well with the recording. So, to analyze what kind of content is needed based on these functional capabilities, I've done a survey and I've contacted some of you who've contributed ideas so far, but anybody at this point, I would be open to collecting additional documents for this assessment. Right now, I have gone through the power of attorney for healthcare from the American Bar Association, the My Directives Advanced Directive document, a piece that an amazing thing that I bought at Staples that's aimed at consumers and teaching them how to do all different sorts of things that require particular expertise and explained in a very straightforward way. So how to create a living will and power of attorney for healthcare. It's like a kit that walks you through that. I have not yet added these other 3 from the top here, the La Crosse Region Power of Attorney for Healthcare document, one from the Veterans, the VA, Advanced Directive Durable Power of Attorney for Healthcare and Living Will, and then the Oklahoma Bar Association has an example. So I have those 3 to still go through. An Advanced Directive document that comes from an organization called 5 Wishes. And just the other day, I found one from Compassion and Choices. They have a kit, a toolkit that's called Good to Go. And these resources are being compared right now to allow us to take a systematic approach to understanding what content is in them, what content is common, similar, dissimilar, etc., so that I can establish a standard for the content. And the system that I'm using is to create, I call it my Jeopardy approach. As you look through and categorize all the different types of questions or types of information that the forms are suggesting need to be written down, I create a Jeopardy question that classifies all those similar data points together. And from that sort of longer Jeopardy question, fairly precise longer Jeopardy question, we create a shorter kind of concept from that. And then I classify that information if it's more of a living will in the category of what we consider living will, or in that category of organ donation and upon death stuff, or the me, what I'm calling the me questions that really ask about your goals and preferences and priorities. So in going through this, it's been a very enlightening exercise. Not only have I found places where we have very equivalent types of questions being asked and a lot of central tendency to be asking similar things, but we also find some cases where there's matchup but broad to narrow, where some questions are bigger and kind of encompass what 2 questions in another form are handling. And it's my hope to be able to establish some content standards based on these standardized questions so that we'll at least be able to know if the information in the document is addressing the same question or a slightly different question or a totally different question. Does that make sense to folks? What I'm hoping to get as feedback from this team is I will send out, when I send out this PowerPoint presentation, I'll send out the list of samples that I'm looking at so far, with the idea that you guys could think from your own experience if you've run across other examples that you feel would improve my analysis by considering something that is different or important in some way other than the ones that we're already looking at. It's a pretty systematic process at this point that it would not be hard for me to take on a couple more samples if we identify them. And if you think any of the samples that I'm looking at right now are especially bad or inappropriate, I'd also be interested to hear your thoughts on that.
Lisa, Terry O'Malley.
Yes.
In the CDAR2 2013 update, longitudinal care planning packet that went through HL7, there is a section on advanced care planning that did the same, took the same approach you did, but probably didn't get to the level of granularity that you have. But it might be worth a circle back because that's already been through ballot.
Definitely.
And
I have gone through all those templates, and I'm aware of that set of SNOMED codes and kind of have a plan for how all this fits together. So thanks for that heads up. I will, I'll send something out to this group that'll be informative about that work as well. And that is a good suggestion. It's in my mind. I just didn't have it on the slide yet, so will do.
It's okay. I can't see the slides, so that's all right. the other question is things like you know, consent for autopsy and donation. I wonder if those perhaps go into the parking lot for next time around, because I think they're a little distracting from the main point of having people's priorities about their care while they're alive. But I may be wrong in that, so maybe it's an important part of getting closure when you're near death.
Sure. Yeah, it's good to know where the dividing lines are, and it's the kind of thing that, you know, sometimes time becomes a limiting factor also, and if we had to, you know, decide what content needed to go into a parking lot so that we can get done on time, having some options like that seem less like the others, it's definitely good to know that.
Terry, this is Stephen Chu here. I do not think that we would want to consider pushing back on organ donation and also autopsy choices for the reason of some of those choices are heavily tied to religious and also personal beliefs. I think we ought, this wouldn't be one of those that I consider as edge cases. I think for some people it might be very important, so I think we probably need to consider allowing that.
Yeah, this is Melissa. I agree with Stephen. I think that a lot of times at these times, your final wishes happen to coincide with your advanced care planning. And, you know, a lot of times you don't get choice in autopsy. That may not belong there, but certainly organ donation does, I think.
Yeah, and for myself, going through this with my own elderly parents, I found that including this was important to have the right conversations, and that the care plan document helped guide us to look at what we should talk about as a family. And so it gave us the opportunity to talk about these two important issues, which, you know, if I didn't talk about them before my parents passed away, then I might not have known what their thoughts were on it.
And burial considerations also, although that might be a back burner item.
Lisa,
yeah, I have bumped into burial considerations, yes.
Lisa, it's Jeff Zucker. I realize you're not trying to converge on an answer here at this point, but if Dr. Fine is still on, I think I've heard him give some very interesting clinical reasons for the autopsy and the organ donation side. And if Dr. Fine, if you're still on, I don't want to put you on the spot, but if you could just throw in a minute on that, it would be interesting, just so that we don't rush to eliminate things that might have different perspectives.
Yeah, I think I would strongly advise against eliminating either of those items. The organ donation is obviously important just in terms of the good we do, and it's a natural link as we move towards donation after cardiac death. I think that can even become an important additional feature in advanced care planning documents. We've got some as yet unpublished, but we hope to have published results from early experience with the MyDirectives platform, where those questions are asked and they don't seem to be disturbing anybody, and they're being filled out. And I think the autopsy thing as well is kind of fascinating, that a lot of people say, yeah, if it would help somebody, I'm happy to designate that I'd be willing to go along with autopsy. And I think that takes a big burden off of surrogate decision makers. So I would just encourage you, I would encourage this group to leave those in there. They're very simple, and we've not, at least in a preliminary review of kind of early experience with the MyDirectives platform, have not seen those to be problematic in any way, shape, or form. So.
Great. We won't throw them off the bus. We won't throw them on the bus. Throw them off the bus.
I withdraw my suggestion.
Okay, there's a good debate. So, you know, I wanted to be able to open up the floor at the end. I was hoping to have about 5 or 6 minutes to let folks just say whatever they'd like to say. But before I do that, I wanted to give a little plug for anyone who does decide that they're interested enough at a level that they want to participate more in the governance. It's not required, because this project will benefit from all of you showing up once a month and giving me this kind of feedback. We'll pour that right into the project. But if you do want to participate at higher levels, there is a listserv, which is a sort of an email feed that the Structured Documents Workgroup uses to discuss things, sometimes controversial things like this. We'll have a very interesting thread of discussion that will take place in this email forum. And if you want to become a part of that listserv group so that you can see what gets discussed about patient advanced care documents, you could join. And your input would definitely be valuable and appreciated, because sometimes a narrow technical set of people could take a conversation in a direction that doesn't make sense, and a few well-placed expert comments can, you know, sort of help straighten that out. So you would be more than welcome to join and watch out for conversations regarding this project and contribute. The other thing, when the time comes that we produce a ballot that will receive public comment, it is an opportunity for you or your organization to put official suggestions and requests for change into this growing or advancing piece of work. And HL7 has a way that even a non-member for $400, which is small compared to their usual membership fee, you can have kind of this one-time participation. So if you get to December and you're thinking, gosh, I'd really like to read that document and put some comments in against it, we can show you how for a small fee. So somebody gets to make closing remarks and let me know if there's anything that really jumped out at you as a big issue that we've just missed. This would be the time to say something about that. Or if you're not comfortable bringing it up here tonight, you can contact me by email or call my cell phone. I live in Eastern Time Zone, and I work just about around the clock. But you can, you know, pretty much call me during business hours, and we'll be in touch somehow. I'm really all about trying to make it easy for you guys to contribute your deep thinking on this subject and help pour all of that prior knowledge into the standard that we're developing here today.
So, Lisa, this is Judy, and thank you for your leadership on this. This is very exciting. I have 3 quick questions, actually 1 question, 2 comments. One is with regard to the non-membership participation. If I wanted to join with that 400 out of my hat from the Social Work, Hospice, and Palliative Care Network, I guess that would be the way I would do that.
Yeah.
And then the other 2, just in terms of things that are missing and other input to consider along the way, are we anticipating that for the future that we'd be able to capture somebody's video advance directive, something like on a YouTube? Just something to think if we're moving to the future. And the other is, I know you've done a great job of looking at some of those examples that you put out. Clearly, that's not an exhaustive list, and I'm wondering how exhausted do you want that list to be?
You know, for me, it's a time consideration. So I'm trying to get a good sample. Like if you had one that was really different, one, for example, that I was just challenging myself the other day, I was looking to say, do I have anything that's really I would consider sort of a religious representation? Like, does the Catholic Church put forth a document that their parishioners can use? You know, maybe that would be. I'm looking for a set of. I want the sample to be broad in terms of the different perspectives that it might represent.
Okay, so we can send those to you email.
Okay, thanks. Yep.
Lisa.
Okay, closing comments,
it's
anybody?
Jeff.
Jeff.
Yeah. Again, I want to thank you for your leadership on this, and just as Judy just said, you made a comment about 35, 40 minutes ago, I think, if I understood correctly, and this is a lot of information, so I might have gotten it wrong. This is the first time a coordinated effort's been taken to try to give some structure and standards to the advanced care planning space, which is critical, and we're thrilled to be a part of it. But I think you made a comment about a mistake that was made in the past, that because that was made, we're dealing with some issues in healthcare today, and because of that, we want to learn from that experience and not replicate that. If I got that right, could you just recap that real quickly so that we all understand the importance of what we're doing?
Sure, sure. The story that I had shared previously about this is just regarding use cases that have to do with giving people the ability to control the sharing of their information or not. And what I found as, early, 5, 6 years ago, when developers were designing systems, you would never see a use case where the person got to decide where their information would be shared. And as a result, systems were built that didn't really take that, I call it like opposite force, into consideration. So they were built to obviously allow for sharing, because the use cases were all about, the good that would come from sharing. But because there were no use cases that talked about either the problems that could come from sharing or the good that could come from not sharing, the systems were not designed to really build in the kind of controls that would put the consumer in the driver's seat on where their information goes and knowing how it's being shared and used. So my point in here was that we wanted to have the scope of use cases be as complete as it should be, so that we don't have too narrow a focus and consequently design something that is sort of dwarfed in a space that it should already have in its scope.
Okay, that's what I thought you had said, and if Chaplain Johnson Remington is still on the call, Melinda, any of the consumer advocates, that's a very big point. I don't want to speak for Scott, but it's one of the missions that we have as a company. We built the system for the consumer to be at the center, to not only give permission, but then to rescind it if your life changes and you no longer want someone to have access. And you have, our belief is the consumer needs to be in control, and if they don't feel they have that control, then they don't take the time to create a good plan in the first place, because they're not confident that it's really going to speak for them, and that they don't want to abdicate that control. So there's sort of a behavioral economics, a socioeconomic behavioral economics concept around that that's more than just technical. It gets at consumer behavior. I realize this group probably doesn't touch on that, but it is, I wanted to make sure I understood your comment specifically, because it's so core to how we built our company. So thank you for clarifying.
Sure, no problem. Thanks for asking. Okay, we're at the top of the hour. Thank you again, everyone, for your participation. I look forward to working with all of you as we go through this process together. You'll be getting lots of email from me, and feel free to write back, send me things, your thoughts, and we'll set another meeting in a month's time. Thank you very much.
Great. Thank you, Lisa.
Thanks,
everyone. Bye.
Thanks, Lisa. Bye.
Thank you. Bye.
Bye.
Thank you.
You're welcome. Thanks for coming. Bye.
Lisa, this is Joe Schneider. Did I miss the phone call?
Hi, Joe. You did. We just were finishing.
Oh, okay. I'm now in the Eastern time zone, and my